Enema Part 2. How to perform enema. Equipments: a tray containing the following: rectal catheter, enema can with tubing, lubricant, pitcher with hot and cold water, solution as ordered by the physician, toilet paper, kidney basin, working gloves. Second, apron or gown to protect the uniform, bedpan with cover. Third, waterproof underpad. Fourth, irrigation stand or a intravenous stand. This is the picture of the equipments. Assessments. Assess status of client. Last bowel movement, normal versus recent pattern of hemorrhoids, mobility, bowel sounds, presence of abdominal pain. Determine factors indicating need for enema and influencing the type of bowel pattern of enema used. Also establishes baseline for bowel function. Second, access medical records for presence of increased intracranial pressure, glaucoma, or a recent rectal or a prostate surgery. Condition contraindicate use of enemas. Third, inspect abdomen for presence of distension. Establish a baseline for determining effectiveness of enema. Fourth, determining client's level of understanding of purpose of enema allows nurse to plan for appropriate teaching measure. Fifth, check client's medical record to clarify reasons for enema, determines purpose of enema administration, preparation for special procedure or a relief of constipation. Sixth, review physician's order for enema. Order by the physician is usually required for hospitalized client, used to determine how many enemas client will require, type of enema to be given. Preparation: first, the patient should be encouraged to empty both bladder and bowels before the procedure. Second, before administering an enema, ensure the patient's privacy by closing the door of the room. Third, have the patient underdress completely from the waist down. Fourth, position the patient on the bed on his or her left side with the top knee bent and pulled slightly upward toward the chin. Position for the enemas according to the age. For 0 to 2 years child, this is the position for enema. For 2 to 12 years child, this is the position for enema, and more than 12 years, this is position for enema. Step number first, inform client about the procedure. Reason: to promote cooperation, to minimize anxiety. Step 2, wash hands. Reason: hand hygiene detects the spread of microorganisms. Step 3, organize the equipments. Reason: for efficiency. Step 4, place rubber sheet under patient's buttocks. Reason: waterproof pad and rubber sheet protects bed lining. Step 5, prepare solution, making sure that temperature of the solution lukewarm, discomfort of about 105 to 110 Fahrenheit. Reason: warming the solution prevent chilling of the patient. Step 6, allow solution to run through the tubing so the air is removed. Clamp tubing. Reason: although allowing air to the intestine is not harmful, it may further distend the intestine. Step 4, place the container on the bedside irrigation stand not more than 18 to 24 inches above the buttocks. 18 to 24 inches. not more than. Reason: gravity forces the to enter the intestine. The amount of the pressure determines the rate of flow and the pressure exerted on the intestinal wall. Step 8. Position the patient on sideline position or seam position, knee flexed. Reason: allow the enema solution to flow downward by gravity along the natural curve of the sigmoid colon and the rectum, thus improving retention of the solution. Step 9. Place bedpan within easy reach. This is the bedpan. Reason: place bedpan for the desire to defecate. Step 10. Wear gloves. Lubricate 4 to 5 inches of catheter tip and rectal tube. Lubrication is done by the doctor. Reason: gloves protect nerves from microorganism in feces. Lubrication facilitates passage of the rectal tube through the anal sphincter and prevent injury to the mucosa. Step 11. Gently spread the buttocks. Instruct patient to take slow deep breaths through the mouth. Reason: to relax the sphincter, which will ease catheter insertion by breathing into the mouth. Step 12. Insert rectal tube into the rectum about 3 to 4 inches and hold in a place. Insert rectal tube about 3 to 4 inches. Reason: the tube should be inserted past the external and internal sphincter, but further insertion may damage intestinal mucosa membrane. Step 13. Release tubing clamp. This is the clamp. Allow solution to flow into the colon, observing patient closely. Reason: introducing the solution slowly will help to prevent rapid distension of the intestine and a desire to defecate. Step 14. If patient complains of cramping and extreme anxiety of the inability to retain the solution, then lower the solution container. Clamp or pinch for a few minutes. Reason: these techniques help relax muscle and prevent expulsion of the solution. Step 15. Administer all the solution or as much as patient can tolerate. Be sure to clamp tubing just before the solution clears tubing. Reason: delivers enough solution for proper effect to avoid introducing of air into the bowl. Step 16. Slowly remove rectal tubing while gently holding buttocks together. Slowly remove the rectal tubing and gently holding the buttocks together. Reason: this is the amount of the time usually allows muscle contraction to become sufficient to produce good results. Step 17. Reposition patient on the comfortable position. Step 18. Documents the results. Documentation. The following should be noted on the patient's chart. Type and amount of the solution used. Color, consistency and amount of the stool return. Condition of anus and the surrounding area. Status of vital signs before and after enema. Description of adverse reaction during enema. Abdominal assessments before and after enema. Presence of discomfort after enema. Client teaching regarding prevention of constipation. This is the chart showing the size of rectal tube, amount of solution, distance of tube insertion, solution temperature according to the age factor, adult, children and infant. Evaluation: were desired outcome achieved? Example of evaluation include: desired outcome met. After the enema, the rectum was free of hard stool, client expelled gas, and abdomen is now soft. Desired outcome met when client state abdominal pain relief after enema. Precautions. Enema should not be used as a first line treatment for constipation. Frequent use of enemas can lead to fluid overload, bowel irritation, and a loss of muscle tone of the bowel and anal sphincter. Never deliver more than 3 consecutive enemas to treat a patient. Enema should not be given to the patient with undiagnosed abdominal pain because the peristalsis of the bowel can cause an inflamed appendix to rupture. Should be used cutaneously in patients who have recent surgery on the rectum, bowel, or a prostate gland. If the patient has rectal bleeding or prolapse of the rectal tissue from the rectal opening, cancel the enema and consult with the physician before proceeding. Do not force the enema catheter into the rectum against the resistance. This can cause trauma to the rectal tissue. Use only mild castile soap, hard, unperformed soap made from olive oil, and dye